Hello and welcome to our first session of Rehab Reels, Conversations on Physical Medicine and Rehabilitation, hosted by Dr. Gwen Soa. My name is Andy Ziegler with the University of Pittsburgh Medical School in UPMC. I'm so happy everyone is able to join us today for a special presentation on health disparities by renowned pediatric rehabilitation researcher, Dr. Amy Haltrow. You may submit questions for our presenters through the Q&A feature on your screen. We will do our best to get to as many questions as possible during the allotted time. Our series host, Dr. Gwendolyn Soa, is the endowed professor and chair of the Department of Physical Medicine and Rehabilitation at the University of Pittsburgh Medical School, and is the director of the UPMC Rehabilitation Institute. Dr. Soa also serves as co-director of the Ferguson Laboratory for Orthopedic and Spine Research and medical director of UPMC Total Care, Musculoskeletal Health. She holds joint appointments in the departments of orthopedic surgery and bioengineering, and has served as a clinician scientist in the Department of Physical Medicine and Rehabilitation for over 15 years. Our featured guest this evening is Dr. Amy Haltrow, a professor and endowed chair for pediatric rehabilitation medicine at the University of Pittsburgh Medical School's Department of Physical Medicine and Rehabilitation. She is also the medical director of the Rehabilitation Institute at UPMC Children's Hospital of Pittsburgh. Dr. Haltrow has received numerous accolades during her distinguished career as a pediatrician, researcher, and healthcare advocate for children with disabilities. And according to the National Academy of Medicine, her extensive research has, quote, uncovered disparities with enormous policy implications for the pediatric population. Dr. Soa and Dr. Haltrow, thank you so much for being with us today and addressing this important topic of health disparities, especially among children with disabilities. Dr. Soa, the floor is yours.
Good afternoon, everyone, and thank you so much for joining us in what I hope will be the first of many conversations that we have over the coming months, now titled Rehab Reels. So it's really exciting to share this with you. We're so excited to find new and interesting ways to connect with our friends and colleagues and really embrace our community. And I can't think of a better way to kick this off than to reach out to you with welcoming Dr. Amy Haltrow, who, as you heard, in addition to being a true academic triple threat, as a renowned clinician, researcher, and educator, is also really a tireless advocate for the patients that she serves. Her career's work in health disparities couldn't be more timely and relevant in this current time. And she's frequently sought after as a thought leader, nationally and internationally, as you heard. So in this really challenging and confusing time of the pandemic and our enhanced awareness of racial disparities, her approach that she uses using data-driven approaches to inform policy and advocacy efforts is absolutely invaluable, in my opinion, to moving us forward and addressing some of these issues head on. And we're really lucky to have her as a leader in this space. We're really glad to engage with you in this dialogue as well. And I know that you're going to enjoy hearing from Dr. Haltrow today and be inspired by her just like I have been. But we also look forward and value hearing from you. And your perspective in this conversation is really critical for us in terms of thinking about things and how we're going to move forward. So we're really grateful to have you join us today, and more importantly, being part of our community and part of this ongoing dialogue. So I'll now turn it over to Dr. Haltrow to share her knowledge on this important topic, and we look forward to discussing with you. Dr. Haltrow.
Thank you, Dr. Soa. It is my pleasure to speak to you all about an issue that's very near and dear to my heart and hopefully near and dear to yours. So the official title of my talk is Health Equity and Social Determinants of Health for Children with Disabilities and Other Special Healthcare Needs. But perhaps a more appropriate title is this: We've got a lot of work to do, people. I have some funding disclosures, but first what I'd actually like to do is take a moment to acknowledge and thank the previous inhabitants of this land, the Adena people, the Mahaganila, and then the Delaware, the Iroquois, and the Shawnee tribes. We thank them for being stewards of this beautiful land that we now sit upon. I have three important objectives that we'll go through during this presentation. First, I'm going to do some stage setting by defining health equity and social determinants of health. And then I'll go through a bunch of slides and information that detail how the social determinants of health impact children with disabilities, children with health complexity, and other special healthcare needs. And throughout this presentation, I'll be taking some time to review some of the COVID-19 pandemic impacts. I'm going to start us off very broadly, and I'm going to do this because this is how we set the stage for how we understand the social determinants of health. If I asked you all to define health, it might seem simple at first, but it might be actually hard to come up with a succinct answer. Is absence of disease health? I don't think that that fully gets at the concept. And for me, while I was training, I learned from the great wisdom of the authors of this report, The Children's Health and the Nation's Wealth. This report was published by the Institute of Medicine, now known as the National Academy of Medicine, in 2004, and it defines child's health. And for those of you who are rehabilitation medicine folks, this is just going to resonate so strongly with you. A child is able to be healthy when they are enabled to develop and realize their potential, satisfy their needs, and develop the capacities that allow them to interact successfully with their biological, physical, and social environments. This just really speaks to me as a pediatric rehabilitation medicine provider, because that's what we're doing. We're helping children grow and develop their potential. We're helping them build their capacities. And this, of course, is happening over time and also in a context. And it's impossible to separate what's going on for a child's health from the context in which they live. And so if we're to understand children's health, we need to understand their underlying biology, their choices and behavior, and then also the physical and social environments in which they're living. And then there's this greater milieu of policies, services, and supports all happening. And this builds over time, which is how we get to kids as adults thriving. Having that definition of health sets the stage for us really to very easily understand what the social determinants of health are. And these are the conditions in which people are born into, where they live and learn and play, where they work and where they grow up. So we can think about those factors at the nexus, so very individualized factors and then interpersonal factors. And then we can also be thinking about health system factors or geographic variables, such as being in a rural area, perhaps with less access to high quality care. There are also very important cultural factors, things like discrimination and racism, and for the population of children that I take care of, the stigma of having disability. All of these are the social determinants of health. So when we think about health equity, I use this definition because it's both an outcomes definition and then it sets us up for some important processes. So health equity just means that everyone has a fair and just opportunity to be as healthy as possible. So for me, I take that as whether or not you have a disability or a pre-existing healthcare condition, whether you live in Arkansas or in New York City, that everyone has that fair and just opportunity. So that's the outcome that we have a goal for. And that means that we have to do things or have processes to achieve health equity. And what that means in terms of breaking down barriers is that we are removing those obstacles to good health. And those obstacles include poverty and discrimination, and then their downstream consequences. And that can be lack of access to good jobs with fair pay, lack of a quality education, lack of stable housing or safe environments. And of course, for those of us who are in the healthcare sphere, lack of access to good healthcare. So I know some of you out there are probably social workers or trained in psychology. So this slide is for you. This is Maslow's hierarchy of need. When we're talking about what the social determinants of health are, we are talking about these bottom pillars, the most fundamental things. So having safe and clean water to drink, clean air, food, shelter, those basic physiological needs. And then the things above that, and they include resources and access to healthcare and personal security. It is upon those foundations that we are building to what we want for all children. So as children are growing and developing, they're learning and developing friendships and understanding intimacy, having a sense of connection. And then on top of that, they're building their self-esteem, they're developing their autonomy, they find their strengths and their freedoms. And then that's where we get to self-actualization, the top of the pyramid. And what we want for each individual that we serve is for them to be the most that they can be the most that they desire to be. And that is what health equity would give us, that opportunity for everyone to be fully self-actualized. So we're here in Pittsburgh, so there would be no way I would do a presentation without acknowledging the greatest Pittsburgher, Mr. Rogers. So Mr. Rogers has a neighborhood, and I have it in this picture here. But I want to do this to illustrate some of the issues around challenges in achieving health equity. Some of you may be familiar with the concept of the medical home, which is not just a location of care, but it's a care where those connections are made. So personal doctor or nurse, a place where you get your ill care and your well care, that you get care coordination if you need it, that the care that you receive is family-centered, so you feel like a partner in that care. And then also that you have referrals if you need referrals. So this is the basic standard for pediatric care. But we know that there's so much more than just the medical home, which is why I want to talk to you about the health neighborhood. So imagine here a child living in this very beautiful house on a very lovely street, and her pediatrician's office is right nearby. And even better than that is that if she needs quaternary care, Children's Hospital of Pittsburgh level care, she can get it in this building. And here is her school. It's a top-ranked school. There's a lot of tax money to have good programs in the school. And so she has access to a quality education. She also has access to this trolley, which is going to take her where she needs to go. But what if she lived over here in a rural area where there wasn't access with transportation and it wasn't easy to get to a doctor or even a hospital that could provide basic level care? Or what if there was something nearby that was emitting toxic fumes? That changes the neighborhood or the environment in which the child lives that can influence their health. These are the social determinants of health that we're talking about. And not all neighborhoods are the same. So this is still Mr. Rogers' neighborhood, but we don't always see it in the pictures or in the frame. This is that little girl's house that I was just talking about. But what if that little girl lived not there, but here in a trailer park? Her home situation is markedly different. She might not have stable housing. They might be food insecure. And so the basic foundations in which she's building her healthy future, in which she's hoping to set up her life to thrive, are not as stable as the girl living in this house. And this is what we're talking about when we're thinking about what drives health outcomes, the social determinants of health. So I told you there are two major categories, poverty and discrimination. And we're going to talk about both of them in this presentation. I'm going to start out very briefly with discrimination with a focus on racism. There's lots of different types of discrimination, ableism, for example, against people with disabilities. But for this presentation, because it's so pervasive, we're going to spend time talking about discrimination in the form of racism. And what I am going to do is show you a series of slides that have data points that show differences by race. And what I'm doing there is not saying that those racial differences are driven by underlying biology. I'm saying that they are being driven by discrimination, by structural factors such as structural racism and racism that's personally mediated. And I'm going to describe to you how that happens, but I want you to understand that when I'm showing racial differences, I'm not ascribing it to something that's biologically different, such that they're more likely to have a disease. That is certainly true for certain health conditions. So, for example, cystic fibrosis, much more common among whites, and sickle cell disease, much more common among blacks. But we're just now talking in general. So the two articles that I want to point you to here are The Impact on Racism in Child and Adolescent Health, which is a clinical report from the American Academy of Pediatrics that came out last year, And then understanding social inequality and racial discrimination. From that paper, we have this diagram. So what it shows you is there's exposure to racial discrimination. That's at the micro and macro levels. And that causes both biologic and psychological responses. So all of these things, changes in your allostatic load, which then can reach the child and the family and their future in terms of at risk for things like chronic illness and disability. And so this is how we're framing our understanding of discrimination and its impacts on health outcomes. So children with special health care needs, those are just children who have health conditions that impact them, meaning they need more health services or related services, or that their health conditions cause them to have a disability. So if you're Black, you're just more likely to have a special health care need. 18% of all children, this line here, have special health care needs, but 25% of Black children do. So children who have a health condition that is associated with a limitation, that's a little under 11% of all children, but 14% of children who are Black. To move us on to poverty, I just want to do some frame setting here. Poverty is common. About 16% of children live below the federal poverty level. That's 12 million children in the United States. That number is going to get worse in 2020 related to the pandemic. But that doesn't tell you the whole story. 43% of children live in families where the income that they have cannot meet their basic needs. So the federal poverty level is a helpful metric, but it's not the metric that really tells you whether children are set up to thrive. And I want us to keep that in mind, because when we think about poverty, we're thinking about just one threshold, and perhaps not the best threshold. You guys maybe have heard the debates about minimum wage versus a living wage. Well, I'm going to share with you from the National Center of Children in Poverty a basic needs budget calculator. So I did this for a family where it's a single mom with 2 young children. And then what it does is, because they live in Washington, D.C., it calculates how much things will cost monthly and annually. So rent is $20,000, food is almost $7,000, and so on. And what we get to is an annual total of over $72,000 a year. So of course you can't make that on minimum wage. You can't make that on 2 minimum wage full-time jobs. That requires an income of $35 an hour. So this is not what people are actually able to do. And so when we think about what our basic needs are, we recognize that families with the types of jobs they have aren't able to do that. Now, race and poverty go together. Poverty and discrimination track together. This is just a 10-year period graph of child poverty by race. So that first bar, the lowest one, 11% of white children live in poverty, compared to 26% of Hispanic children, 31% of Native children, and 32% of Black children. That's a lot of children. So as you can see, if you are a minority, you are more likely to be poor. These things go hand in hand. And this slide is one that maybe makes you feel like you want to cry or scream, or at least it does for me. This is extreme poverty. These families have less than 50% of the federal poverty level in income each year. It's the same 10-year graph. And what I can tell you is that families who make less than 50% of the federal poverty level, they're in crisis. They don't have stable housing. They're food insecure. The very basic tenets of Maslow's hierarchy of need are just not being met. That's 5% of white children, 10% of Hispanic children, 15% of Native children, and 16% of Black children. There should be no children that live under these circumstances. So I'm going to introduce you to a color scheme here. It's going to show up many times. And this is how I'm going to show you income. So the lighter the green, the less money you have. The darker the green, the more money you have. This is just broken up by federal poverty level. In this column over here, these are children with special health care needs. They have health conditions that impact their lives. These are all the other children. This is about 18% of children. This is 82%. And what you can see here is that just more children who have special health care needs are poor or near poor. Nearly half of them, compared to 40% of other children. And then when we look at the children with special health care needs just themselves as a population, so just that 18%, I've divided them into children who are more complex, meaning they need more health care, or they have complicated health conditions. Those are in purple. And then those children who have more routine health conditions. And what you can see is when you're more complex, you're more likely to live in poverty. The same relationship that we saw for special health care needs also tracks for disability status by income. So again, it's nearly 11% have health conditions that are associated with activity limitations, and it's much more common amongst poor children and near poor children compared to well-off children. So what's happening here? Well, people don't have access to good jobs with fair pay. So this is just a 10-year graph, again, for all families. And what we can see here is that 27% of all children live in homes where the parents don't have secure employment. That means they can't have a living wage because they don't have jobs that they stay in routinely. And how has that been changing in the pandemic? Well, this is from the Brookings Institute, and what they did is they graphed people out by their income, low to high, and then they asked them whether they had a job or income loss because of the COVID pandemic. So when you were in the lowest income category, you were the most likely, 29% of those individuals reported having either a job or income loss. These are the exact people who don't have the extra resources to weather the storm. So the most well-to-do, only 20% of them had a job or income loss, and they are the most likely to be able to weather the storm. And this has really substantial implications. So these in the dark blue are people who had job or income loss at all income levels, and in the gray, no job or income loss. And then down here are the various outcomes: trouble paying the mortgage or rent, problem paying bills. And I just want to focus us right over here. There, people are putting off medical care because they can't afford it, putting off filling a prescription because they can't afford it, being food insecure. So those who've had job or income loss were just so much more likely to report that they were food insecure. They were going hungry. And just over the past decade, we can see this trend in food insecurity for children. 17% of children are food insecure. It should be very obvious to you that you have to have good nutrition to be healthy and to thrive. And we know we're not doing well by these children. These are the same children who are living in poverty or near poverty. And this number is certainly much higher during the pandemic. And what about stable housing? Well, a marker of stable housing is whether or not more than a third of your income goes to housing. And 31% of all children live in homes where the housing actually costs more than a third of their household incomes. In fact, it's pretty scary. For the people who are the poorest, the most likely to be housing insecure, renters living in poverty, they spend 63% of their income on rent. That means just dips in their income a little bit really influence whether or not they can get their prescriptions filled, whether or not they can put food on the table. So we have a huge problem making sure people have stable housing when they're poor. Maslow's hierarchy of need, it's the very bottom. So what about making sure kids have a quality education? I am going to share with you some graphs here, and this is from National Kids Count. What this is showing is the percentage of 8th graders below grade level for mathematics by race. So these are underperforming. A majority of all children are underperforming in math. 57% of white children are underperforming, and 87% of Black children, 81 of Hispanics, and 85 of Native children. So this is pretty stark. We are not meeting the needs educationally of any of our children, and we're doing much worse for children who are minorities. So unfortunately, the colors changed here, but I'm going to walk you through this. This is children who have been expelled from school by race, and this is per 10,000 individuals. So over here are white children, and 20 out of 10,000 white children are expelled from school, in comparison to 44 of every 10,000 Black children. What that means is more than twice as many Black children are expelled from school compared to white children. So this is a problem, in part because it leads us to this, children in juvenile justice. This is also done by race. So these are white children, and this number is per 100,000, 83 per 100,000 white children compared to 383 among Black children. 4.6 times as many Black youth are in detention compared to white youth. And you might say to me, so, how does this relate to children with special health care needs and kids with disabilities? Well, you should just know that not only does poverty track with minority status and disability tracks with minority status, children in the juvenile justice who have disabilities are just overrepresented. These are children who are not having their needs met in relation to what's happening from a mental health and physical health perspective. And part of the problem here is this thing, the school to prison pipeline. I think you probably have heard about this in the news. And what has happened in the school to prison pipeline is that instead of understanding children's behaviors as discipline problems, they're now being thought as criminal problems. And what we see happening is fewer nurses, fewer counselors to serve the children that need to be served, but more resource officers. So when you have a hammer, everything looks like a nail. And that's what's happening in schools. We're putting in police officers instead of getting kids the resources that they need. So when I think about what's been happening during COVID, I have a couple of pieces of information to share for you. So first of all, educational losses are disproportionately impacting children in poverty. They have less access to capability to be able to do remote learning. They're also not getting the services that they need that's delivered more uniquely towards their needs. And yes, there was some income CARES Act relief money put towards education, but it was just a tiny drop in the bucket compared to what was actually requested. In a study that we've done here in Pittsburgh, children with disabilities reported loss of therapy services they were getting through the school district. And this is pretty profound. So these are the basic services that kids with disabilities get to help promote their academic achievement. So now let's just talk about safe environments. We could talk about not having safe water, the Flint water crisis, or breathing polluted air, living near a highway, or what children are experiencing when they have to do active shooter drills in school, or what children at the border are experiencing in detention. But we can also just look at that in collective about living in a safe neighborhood. So this is a family report from the National Survey of Children's Health. And again, I've done this where I've had the poorest kids, the lightest green, the richest families, the darkest green. And as you can see, there's a stepwise increase in the likelihood of having a safe environment neighborhood by income. The richer you are, the more likely that's to be true. Same thing is true when we do this by race. So these are white families, much more likely to report a safe neighborhood compared to Black and Hispanic families. When I show you this data by special health care needs complexity, these are the kids that are most complex. These are the kids who still have health conditions, but are less complex. And these are the 82% of children without special health care needs. What you can see is the kids who are the most complex had the least likely reporting of having a safe neighborhood. What does that mean in the time of COVID? Well, it certainly means something when your parent is an essential worker, like someone who is a restaurant delivery person or works at a gas station or grocery store where there's often a lack of PPE. But then when we think about it for the kids who are the most complex, those are children who often have assistance in their home through home nursing services. And those children often lost those services because it wasn't safe to let in providers who were seeing multiple different people, especially when there wasn't adequate PPE. So this, of course, goes without saying, but in order to benefit from high quality care, well, you need to be able to access it. So let's talk about how we're doing with that. So I talked to you earlier about what it means to have a medical home, and a key component of it is family-centered care, where you have care where you feel like a partner in your care. And the same relationship that we see over and over by income is true here. So that when you're poor, you're much less likely to have receipt of medical home family-centered care compared to if you're more well off. It's a steep gradation. And the same is true by race. White families report family-centered care in a higher rate than Black families and Hispanics and Asians. And putting it all together, when we look at medical home, for children with special health care needs, only 43% of them overall have care within a medical home. But when I break this down by how complex they are, bad news. The more complex you are, the less likely you are to have care within a medical home. You have more needs for that service to work for you, and it less commonly does. And no surprise, when we look at the percentage of kids with special health care needs who get care in a medical home by income, overall, it's about 44%, but there's a gradation such that the more well-to-do families report care in a medical home. But these are the families that need it the most. We can do the same thing by race. White families are more likely to report care in a medical home than Black families or Hispanic families. These are the families where we need the services, and they're disproportionately being received by white families. Now we're just going to take a look at access to care. So unmet need is a great metric for this. What it does is tells you that if you have an identified healthcare need, whatever it is, need for a prescription medication, need for durable medical equipment, it's asking you if you had that need, and if yes, did that need get met? So what I've divided this up into 3 different groups. These are children with special healthcare needs who are more complex, these are less complex, and these are the 82% of other children. Unmet needs are rare, luckily, but they're not rare for children who are more complex. Children who are more complex, 10% of them report unmet need in the last year. So what I'm telling you is that while it might feel like we're all weathering the storm together, we are not in the same boat. And I want to share with you just some memes that have been going around. You've seen this, I'm sure. It's the comparison between equality, so everything is equal, everyone gets the same, versus equity, where we're actually looking at what people need. And I like this very much. But you know what? I like this one better. As a rehab doctor, I'm thinking about this kiddo in a wheelchair who really can't use that block. But here we have a ramp for that child. And we just celebrated the 30th anniversary of the ADA, all about accessibility, the American with Disabilities Act. So it's delightful to see that somebody made this. But one of the problems that I think with that original picture here is that it doesn't really tell the real story. Here we have that original picture, but this is probably more what reality looks like. Through the processes of systemic racism, widening income inequality and policies that promote that, we have people that have to climb out of a hole. And then we have other individuals, people at the very top, who have so many resources that they don't even need or use. So some people say the solution to that is liberation. Take down the fence and then we don't need boxes at all. I think that's a wonderful sentiment, but I actually don't think it's appropriate here. So I am not in favor of it. The fence serves a purpose. It demarcates home runs. It keeps the fans safe. And, you know, in a capitalist society like our own, you don't want people sneaking into the ball game and not buying a ticket. But what I think is really great is this diagram. So yes, we still have a fence, but everyone has this opportunity to see the game. So when you remember the process of developing health equity, what it is we're breaking down barriers. So whether that's in our healthcare practices, whatever type of medicine we practice, or in our communities, all of us can help replace the fence that was blocking the view with a different type of protective fence that doesn't discriminate. It doesn't discriminate based on who you are. It gives everyone a fair and just opportunity. So that's what health equity is. It's a state in which everyone, no matter who you are, whether you have a disability or not, that you have the opportunity to attain your full health potential. And the other factors, social position or other socially defined circumstances, don't impede your opportunity for full health potential. I just have a few resources here. I did most of this work using the National Survey of Children's Health. If you like to look at it, there for the looking. And I believe we are now open for questions.
Thank you so much, Dr. Haltrell. I've known you for a long time, and I think I learn something new every time I get the opportunity to listen to you. So that was great. Thank you so much. So as people are thinking about their questions and posting them for us to discuss, I first want to just thank you for shining a light on these super important issues. And of course, awareness is a very important first step. And you talked a lot about awareness of the issues across the society, but I wonder if we could talk a little bit about awareness within an individual person. So how do we think about what could healthcare workers be doing? What could patients be doing to help their healthcare workers understand some of the challenges that they're going through? How can providers reach out and make sure they're capturing this information? Because sometimes people might not want to share some of these things. And also, are there other mechanisms we can think about this? Can things like insurance companies start to help us in learning about how we can do this? So I wonder your thoughts on that.
So my first point is that we all have a role, no matter who we are. So I think you made an excellent statement when you said, well, as healthcare providers or as patients, how can we do this? Or who else can we engage? Maybe it's the health insurer. A good example with that is that we know from literature that came out of Kaiser, and we're doing it here in our own health system, that making sure people have stable housing is one of the keys to health success. So we can decrease readmission rates if we make sure people have a stable place to live. And that makes sense. And so if there are things that we can be doing collectively, so the insurer is paying attention and gathering the data, and then we're assisting individuals to maintain stable housing, we've done ourselves a big win as a healthcare system, but we've also won for that patient. And that's what we need to be doing. I think one of the things that I hold with me, and I think we all need to hold, is some humility that we might know about, but don't truly understand the circumstances in which other people live. And that while certainly I know that I have faced discrimination, I do not know what it's really like to be a person who is Black, for example, living in this kind of racially charged environment where there's all these structures and there's all this aggressive, personally mediated racism. And so I think there's a piece of us as healthcare providers that need to have that cultural humility, but also that openness and the desire to learn and share. Yeah. And so I think as healthcare providers, we need to seek out trusting relationships with our patients. It turns out that when we ask patients a question, we only let them talk for like 11 seconds. And that's not very much time to get to know them. And it doesn't give us the chance to do active listening and learning. And sometimes that's the most important piece. I had a mom a while back who I had seen her child for a long time and just knew that something wasn't quite right. And she didn't disclose anything to me until I asked. And then she was really very ashamed to tell me that they were going to lose their apartment. And she was going to have to basically do some couch surfing. So when we think about homelessness for children, it doesn't look like homelessness with somebody under a bridge, like we think of in the media or in the movies. It is like staying with friends and relatives, and it is hopping from place to place. But she was ashamed of her circumstance. But the good news was when she trusted me enough to share that with me, I'm able then to set up resources. I don't have it in my doctor's armamentarium, but I'm very lucky to live here and work at an institution where we do have supports and we do have services. So when we think about what healthcare providers can do, first, it's about being open and developing trusting relationships, having that cultural humility. But then it's also about when things are screened for or identified, then setting up opportunities for resources. And there are ways to screen that just can happen on a routine basis in your clinics that can be part of the way you give care. And if health is so much driven by social determinants, we as healthcare providers should really be energized by being able to identify those issues and then help act on them. As a rehab doctor, we know the value of teams. Absolutely. Teams are what makes it possible for us to do our jobs. Now we just need to think of our teams as including the people that will help get resources, and think of our teams as the greater context and communities in which people live.
Teamwork makes the dream work, right? No, it's great. I think it's such an important point about the listening piece and listening to one another. I mean, as we talk about all of these issues, the more we can hear about the experiences others are having, I think the more we're going to be able to move things in the right direction. You several times in your talk alluded to safe environments. And of course, we all think about safety in different ways. You know, a place that you won't fall, a place, especially these days, where you won't become ill. But it's so much more than that. It's so much more than just a safe neighborhood and those sorts of things. And I wonder if you could talk a bit about what we should be thinking of in terms of creating safe environments, and really what's right on the cusp of change. What's the low-hanging fruit that we can start to move the needle on quickly to create safe environments?
So I wish I had a really great answer for that, because you're right. Safe environment means so many different things to so many different people. So if you lived in Flint, Michigan, it was the water that you were worried about and the neurodevelopmental outcomes for your kids who were getting lead poisoning. So that might have been the number one thing. But also in Flint, Michigan, kids were living by highways. And we know that when you live near a highway, you just have much higher rates of asthma, for example. And so what can we be doing about housing is thinking about how, you know, in the long term, how we make sure that we have housing that doesn't put people in risk when they live in that housing. And, you know, the long term is that as we experience climate change, those impacts are disproportionately impacting neighborhoods with higher densities. And so you can already see it where certain neighborhoods, usually neighborhoods that experienced white migration out of the neighborhood decades ago, have higher temperatures. So their extreme heats and extreme colds are worse. They're more likely to have flooding. So there's all these ways that we have designed housing that perpetuates the likelihood of unsafe environments. And I think there's also something to be said about the internal experience of safety, right? So you and I probably have no idea or no concern if we were to ever get pulled over by the cops that we would die in that encounter, right? But you know, my families who have Black children are teaching those children how to behave to try to keep them alive. And they literally fear that a routine traffic stop will lead to their young child's death. And so that kind of allostatic load. So, you know, when I talked about that elevated my heart rate, I kind of felt it emotionally. That's nothing like the routine experience that's happening where that you're having this cortisol rush when you experience these acts and concerns. And so then I think about safety and what we need to do to make sure that we're addressing these underlying problems in our society that lead to these changes. And it's no wonder we see health outcomes related to them. But on the margins, what can we be doing? I feel like some of the things that I do, where we're getting families services so that they have more resources to put towards housing, so that they aren't spending so much we could all be advocating for a living wage and making sure that people are making enough money to survive. And there are places, obviously, that are already doing that, communities that passed living wage ordinances. And so I think those are all things on the margin that we could be doing.
Yeah, thanks. You mentioned in many different parts of that chronic stress. And
Yeah.
of course, one of the aspects of chronic stress is it actually contributes to additional health challenges. And so it certainly can become a self-fulfilling prophecy and a snowball. So I wonder if we could, I do want to hear from our community that's joined us here this afternoon. So I wonder if we can go to Andy and see if there are some questions from our audience.
Sure, yes. We do have a question here, which is, we have in place processes to screen for food insecurity. Do we have similar processes in place for housing insecurity?
So that's a great question. There are a number of different screeners available to do this. And for us at Children's Hospital, we're doing food insecurity screening. And many of us have been talking about adding housing instability screening as well. This is particularly important when I think about the children that I take care of who have a lot of equipment needs. So if you're about to be evicted, what happens is they lock you out of your house and you can't go back in and get your stuff. And while stuff just might be stuff, that's not the same when it's your wheelchair or your nebulizer or other pieces of DME. And so I think screening for housing instability in addition to food insecurity is important. And there are measures that screen for a whole bunch of social concerns like that.
Great, thank you. This question is from Michael, who is a fourth-year medical student. He does say hello to both of you and wants to thank you for this very insightful lecture. He was wondering if you could share your thoughts about what may be next in terms of pandemic management, vaccination, and patient education. Certainly a timely question.
That is such a timely question. So the National Academy of Medicine has actually gone through a process, is taking public comment now about allocation for vaccines. And there obviously will be this issue in which we will not have enough vaccine for everyone right out of the gate and how to prioritize. So what underlies my thinking on this is that we know that people who are minorities have been disproportionately impacted by the pandemic and then the pandemic response. And so each time I think about something, what are the consequences to worsening inequalities? And I think we are likely going to face something where we have to grapple with that related to our pandemic response. We also know that there are many things that we can turn to help mitigate that. One of the things about the pandemic response as it relates to people with disabilities was when we thought lots of places were going to have to ration care because the hospitals would be too full, and how they would ration, and using disability as a marker for why you wouldn't be getting treatment. So even as we're going through it, we're learning from it. And I think that's hopefully something we will continue to do. I wish I had the answer of how we were going to come out of this on the other side. But the thing I do know is that we will have acknowledged and need to face the realities of the consequences of so much income inequality and discrimination that has really opened our eyes to this worsening during the pandemic. Dr. Soa, do you want to add to that?
Yeah, I think that if, I always look, as everyone who knows me knows, I'm always painfully glass half full. And I think if there's any silver lining to what we've been experiencing through the pandemic, it is that we have really brought to the forefront some of these issues and are starting to really grapple with how we can address things in real ways, not putting a Band-Aid on something, but thinking about what can we really do to make a real impact and make a change. And I think, one of the important things that we need to do, and I'd be interested to hear your thoughts or anyone from our community, is how, all of the disparities are contributed to by both our conscious and our unconscious bias and what we bring to the table. And you alluded to this very nicely in your talk that, I can't understand what it's like to be in many different situations. And so listening to that is so important. But I wonder your thoughts and again, others about how we can better start to understand our own implicit bias and address that in ways that can help us be better advocates, better, policymakers, better clinicians, better patients, to start to move these conversations forward. Your thoughts?
Yeah, so I think that for individuals who aren't yet familiar with the idea of implicit bias, it's what's kind of inherently in us that we don't always have at the forefront, but it is important to understand that those things exist and that there's the implicit bias testing. I have no financial relationship to Harvard, but Harvard hosts that, and you can do implicit bias testing for race. You can also do it for disability, for gender, and I think it's really informative. One of the things that I think that would be helpful for us generally to acknowledge is when something identifies a difference. So there's lots of literature that supports the idea that even though we don't think we're doing it, we're treating patients differently based on race. And instead of saying, no, that can't be true, I'm not racist, identify that in fact there are a whole host of factors that make that so. Some of those very structural, and some of those unconscious biases that we ourselves hold. Very rarely does it work to the advantage. I'm going to give you an example. So many of us treat concussions in children, and the protocols for concussion evaluation in the ED do not usually recommend imaging. And those protocols are well tested and based on the literature, but white children are much more likely to undergo imaging than Black children. Black children are much more likely to their care to adhere to the guidelines. So that's the one example that I know where it's been the reverse. But Black children after injury are much less likely to get narcotic analgesia than white children, and their pain is not believed to be real. And we say things in our notes like patient reported 10 out of 10 pain versus what we might say in a white person's note, patient has 10 out of 10 pain. Just these very subtle differences in the way we approach care. I think it's incumbent upon all of us to examine them. And even when you have implicit biases, what you should not then take away from that is that I am an inherently bad person because I have them. It's that I have an opportunity to acknowledge they exist and then do the work to make sure that they're not impacting the care that I deliver.
Yeah, absolutely critical. And certainly those findings that you described exist in the adult population as well. It's not unique to children. We see that all across the board, and in pain management and other types of disability, we certainly see those disparities. I know we're coming up on the end of our time together, but I wonder if maybe just in our last couple of minutes, you've been such an incredible advocate and you found different ways to effectively advocate, particularly for kids with disabilities, but across the spectrum of health disparities. And I wonder if you could just give some tips to anyone that might be listening that's a budding activist and would like to do something to make a change, to make an impact, to get involved. Any tips of how people could get involved and start to move things in the right direction?
So I think the first point is to recognize within yourself that you have something valuable to contribute. So when I started on this path, I had started on this path when I was in residency and was exceptionally frustrated when I couldn't get insurance companies to authorize equipment. And then I'd have to do these peer-to-peers. Yeah, I was pretty good at like shaming the insurance company into doing it, but that is not how I think care should be delivered, because these kids were having long-term unmet needs because they weren't getting the equipment they deserved. And so that put me on a path to do some studying. So I did a master's in public health. But it also then opened my eyes to the opportunity that when you have data, or you can use other people's data, that when that's distilled into information that's digestible, that can be something that you take to your legislature, that you do advocate. And there's lots of different mechanisms by which you can do advocacy. But I think for people who are growing up, becoming healthcare professionals now, recognize that your individual one-on-one patient care is also advocacy, and that you are and I feel like we do this a lot for our patients, is really advocating for the whole individual, the whole person. So not just their disease state, not just their disability, but that we're advocating to get them what they need. And then that means that you have skills already there in advocacy that you can enhance and blossom. And I think, some of the work that I'm the most proud of is the work that where we anticipated that there was going to be difficulty policy-wise. An example is often Social Security income for kids with disabilities is on the chopping block because it's costly in the budget, the national budget. And there was a House proposal which said, well, we're going to tie Social Security income for kids to attendance in school. Well, the idea there is that if you're truant, then your family doesn't get the money. There's a lot of reasons why kids are truant, but it also turns out that kids on SSI were no more truant than other kids. So tying it to their school attendance was worth nothing. And we had that data and we were able to take it. And then that bill just went away. And so for someone who loves data, I get like the double benefit of getting to use the data that I love to shape something that's happening in the policy world. And for me, that's really valuable. So it's about finding your place in advocacy. Maybe you're the person who just wants to do the data, or maybe you're the person that really wants to sit down with your congressional representative, or maybe you want to do both. But there is a pathway because we're all advocates. We all advocate for ourselves, hopefully. We advocate for our patients one-on-one, and then we can think about how we advocate for our patients in general.
Absolutely. You brought up something that I must touch on that actually is one of the questions that came up as well from the group is, truancy and what that means right now. With so many of our kids learning remotely, what does that really mean? And how do we know when they're truant? What are your thoughts about what we can do regarding access to technology? We've certainly seen this in locally Pittsburgh. Pittsburgh Public Schools had to postpone for a week the start of school because they couldn't get enough laptops to the kids. Things that we can do around improving technology to help with this?
So some of the things that we think about that we pay for, why isn't that we can't set up community-based Wi-Fi that is accessible for whatever channels and purposes that we need? In some communities, actually, their entire city just has Wi-Fi and it's just part. And we should think about ways that we can be advocating for that and then getting kids the tools that they might not have at home. But you're right, this is happening over and over. And really, what does it mean when to be suspended from virtual school? We should be trying to minimize all things that inhibit kids from learning and maximize all opportunities for them to learn. So suspension or expulsion from virtual school, probably not such a wise move. And we do need to figure out how we can get those kids what they need to thrive, even in the changed environment.
Thank you so much. And I know we're up against our time. I'll turn it back over to Andy to close us out. And I know there was a lot of discussion and hopefully we'll have a chance to get back to some of those questions as well. But, I really thank you for kicking us off with this Rehab Reels. And I think it was a great discussion and again, couldn't be more timely. So thank you.
Well, it was my pleasure. I'm so glad I got to do this with you, Dr. Soa.
Always fun.
Yes, Dr. So and Dr. Haltrell, thank you so much for such an informative and very important presentation and discussion. For anyone who had a question we were unable to get to today, or if you would like to learn about ways to support the important work of the Department of Physical Medicine and Rehabilitation, please email me at raz37@pitt.edu, which is on your screen. As my phone number is on there as well, so you can certainly give me a call. I want to thank everyone who attended today's session, and please be on the lookout for future events. Dr. So and Dr. Haltrell, thank you again, and have a great night.